interest include novel applications of ultrasound in pediatrics, pediatric onco-imaging, and pediatric intervention. And she was one of the faculty at the pediatric oncology workshop, which happened in Tata last month, which was just phenomenal. So, looking forward to having Diksha take this talk, which is going to be on pediatric neck masses, multimodality imaging approach. Before handing it over to her, just to let you know what is in store ahead. So Saturday, Dr. Vijender Arora is going to speak on radiograph as a mirror of metabolic bone disease. And on Sunday, Dr. Emilio Supsupin is going to speak on spinal vascular anatomy and practical applications. These are our free access webinars for this week. And as you know, certain focus sessions on ultrasound, MSK ultrasound are happening. So with that, I'm going to stop my share and welcome Diksha. Thank you so much for doing this.
Thank you so much for the very kind introduction. And as always, it's good to be back with the Bombay crowd. So I will
once you
just
say
share
Bombay, you have to use the word privilege. Being from
my very proud privilege to be here today. Is my screen visible? No, not yet. No? Now, is it visible?
Visible, but not full screen.
Okay. Okay. So we will get right to it. I'm going to be speaking about multimodality imaging of neck masses in childhood. For the purpose of this talk, I have divided it into two components, which I will tell you. So basically, when we are speaking about neck masses in children, we will see that there are some places where we can give a definite diagnosis, and otherwise, which will be the case in majority, is that we will be giving a list of diagnostic possibilities, right? So diagnostic possibilities will depend very much on the clinical context and the age of the patient, particularly in children younger than 1 year, more so in neonates. You will see a different set of differentials because of their different physiology. You will see more of congenital lesions. Then after that, we will come on to a morphological classification and finally see how location helps us decide. So just a brief overview, we are all familiar with neck spaces. There are paired neck spaces and unpaired neck spaces. This is the suprahyoid neck in short. So this is the pharyngeal mucosal, the retropharyngeal paravertebral space, and then there are these paired spaces, which are the parapharyngeal, carotid, masticator, parotid, buccal space, also the submandibular and sublingual space. Then when we come to the infrahyoid neck, it becomes a little bit simpler. The pharyngeal mucosal space will now continue as the visceral space. The paravertebral space and the retropharyngeal will stay as such. And what continues is the posterior cervical, and your carotid space will continue as such. So we will be referring to these again and again during the course of this talk. That's why I just wanted to remind you about how the classification looks like. So we are now talking about children in general, and then we will come on to younger children specifically. First of all, let's talk about cystic masses. What are characteristic cystic masses in children? So this is a 2-year-old boy who presented with fluctuant neck swelling since birth, right? So this is the neck swelling you can see. And what is characteristic in addition to the morphology is the location of the cyst. So you see this is anterior to the sternocleidomastoid and in relation to the angle of the mandible. It has a well-defined wall. There is no internal heterogeneity, no septae. There is just this thin wall, simple cyst. And if I tell you that this is present since birth, what will you say? This is a branchial cleft cyst, right? So if they are lower down in relation to the thyroid, they become third or fourth branchial cleft cyst. If they are in relation to the angle of the mandible, this is your characteristic location for a second branchial cleft cyst. Okay, now coming on to the next lesion. So this is a 3-month-old girl who presented with left-sided neck swelling. So there is this huge neck swelling which is seen again since birth. And so this is left-sided. On the right side, she also has this discoloration. There is this erythematous lesion. She was carrying an ultrasound from outside which showed this large cystic component to the lesion. But there were also some solid areas which were showing vascularity, although they had not been well characterized. So, for characterization, based on the erythema, what are we dealing with? We know that we are dealing with a vascular lesion. So, what will we go ahead and do? We will go ahead and do a contrast MR, preferably a dynamic contrast MR. So, again, what do we see in the contrast MR? There are two components, or rather three components to this lesion, right? So, there is this cystic multilocular lesion. Okay, along the angle of the mandible. Then, along the floor of the mouth, there is this solid T2 hyperintense component, which is showing what kind of enhancement? Intense enhancement. And then on the right side, where there was that erythematous lesion, you see this more of homogeneous soft tissue, which is involving mostly the posterior cervical paravertebral space. And again, this is showing intense kind of enhancement. So this is a vascular malformation. And what kind of vascular malformation? So there are at least two morphologies in this, right? There is this purely cystic, which is only showing minimal wall enhancement or actually no enhancement at all. And then there are these enhancing areas which are intensely enhancing. So that is why, based on the morphology of this, which resembles a port wine stain, or it's also called salmon patch. So this part would be the capillary malformation, and the swollen part would be the lymphatic malformation. So this is multi-compartmental lesion with cystic spaces and enhancing hyperintense soft tissue. So just to give a perspective on what do congenital vascular lesions look like, this is just a clinical perspective, right? So like I said, clinical context and age are very important. So colored lesions can be of two types. If you see a mass associated with it, it will most likely be a vascular tumor, that is a hemangioma. If there is no mass but more of a uniform kind of discoloration, it will most likely be a malformation, a capillary, or even sometimes a venous malformation. If it is not colored, then you're most likely dealing with a lymphatic malformation, but sometimes even tumors can present with fluctuant masses. So just to bring you to my favorite ISFA classification of vascular anomalies. So we know that there are tumors and there are malformations. Tumor is the prototype is hemangioma, whereas the poster boy of vascular malformations are, we know, veno-lymphatic most commonly, and then there can be capillary AVMs, AVFs. And when they combine in various permutation combination, you get these capillary lymphatic, you get capillary AVM, you can get a host of combinations. So just to bring to perspective, capillary malformations are actually often associated with this mutation, right? PIK3CA, which means that there will be associated overgrowth many times with these malformations, particularly when they are seen in the limbs, less so in the head and neck. So there are these overgrowth syndromes like Klippel-Trenaunay and Venoclose, which are associated with mutation and capillary malformation. The poster boy of capillary malformations in the head and neck is Sturge-Weber, where you have your characteristic port wine stain, which shunts the blood away from the brain and causes intracranial calcification. Okay. From cystic, now we move on to solid. First of all, we are going to speak about those with characteristic morphology, where you can look at the mass on imaging and say that, yes, I know what we are dealing with. And the buck stops with the radiologist, that is with you. Right? So this is a 1-year-old girl with progressive swelling of the lower lip. So again, we already spoke about ISFA classification. Now this is a mass lesion, right? There is progressive swelling. And what is happening? It is again in the floor of the mouth as well as along the gingivobuccal sulcus. It is T2 hyperintense, and it shows progressive intense enhancement on your dynamic post-contrast images, right? So T2 hyperintense with intense enhancement. What would you say? You would call it an infantile hemangioma. So what is an infantile hemangioma? It is a vascular tumor, and what is characteristic is that it is relatively quiescent during the first 6 months, undergoes the proliferation phase during the next 6 to 9 months, and then gradually involutes over the third 6 to 9 months, right? right? So if you see this kind of lesion on imaging and there is characteristic history that it's suddenly entered sort of a growth spurt during infancy, particularly late infancy, you can say that yes, we are dealing with an infantile hemangioma, nothing further to be done. Child can be kept on follow-up. Occasionally, propranolol is used if they are very large lesions. Okay. So first lesion with characteristic morphology was vascular tumor. Now, next lesion which we will deal with is a fat-containing lesion. Okay, so again, 18-month-old girl with enlarging neck mass. Right. So what do we see on the CT? That there is this fat containing lesion. Again, not much enhancement, only some thin septae. And what is it doing? It is insinuating, right? So it is it is crossing neck spaces. It is causing some mass effect on the airway as well, which is why she is having difficulty feeding on the airway and aerodigestive tract. And what is it doing to the bone? If you notice, there is no bony erosion anywhere, right? There is only scalloping, which means it is slow growing. So pressure effect means benign. And we know that this is characteristic morphology because it's large insinuating. We call it a lipoblastoma, right? Made of lipoblast. If it was made of mature fat cells, we would call it a lipoma, in which case it would not be an insinuating or a fast growing mass like this. So again, this is characteristic lesion. Why? Because age, presence in young children, it is fat containing, and also because it insinuates, it does not infiltrate or invade surrounding structures. So this is a lipoblastoma. Okay, now coming on to third lesion with characteristic morphology. So this is an 8-year-old boy with kyphoscoliosis and cafe au lait spots. So we already know what we are dealing with. We are dealing with the syndrome called neurofibromatosis. This child undergoes a radiograph, lateral radiograph, which shows this extensive retropharyngeal soft tissue. So we do an MR to see that what is the retropharyngeal soft tissue. And what do we see? Lots of these lobulated masses in the retropharyngeal as well as in the paravertebral region, right? And we actually do a lot of whole body MRs for these neurofibromatosis patients because they have lesions all over. They also have nerve thickening as well. So whole body MR is a good modality to use in syndromic patients, right? So we have done this whole body MR. You can see that there is that deformity and there is extension of these masses into the upper mediastinum as well, with extensive extension also seen along the axilla, along the soft tissues of the neck. And what is this story that we are talking about? The target sign. What is the target sign? So you see these central black dots within the lesions. So what is a plexiform neurofibroma? Insinuates along the nerves. And what is this central hypointensity? It is the central fibrosis, which is why it appears black on MR. Again, this is characteristic, and you can say on imaging that yes, nothing further to be done. No biopsy is required. So this is a plexiform neurofibroma. Okay, so these are mostly all benign lesions that we have dealt with so far. Now we will go into the realm of infiltrating or aggressive lesions and see how much help we can be to our clinical colleagues when there are these kind of lesions. Okay, so this is a 3-month-old boy with respiratory distress. Again, he underwent the radiograph for the respiratory distress, and there is this large mass which is seen actually on the right side of the neck, for which an ultrasound was done. So this is the ultrasound where you can see that there is a soft tissue, homogeneous, solid lesion, which is pushing. What are these? These are the vocal cords, which is pushing the airway. This is your thyroid gland, again displaced towards the contralateral side. There is some vascularity within. So when I tell you that there is a 3-month-old boy with a solid infiltrating mass, what is the first differential diagnosis that should come to your mind? It is neuroblastoma. Okay, we will be seeing more of these, but so this was proven to be a neuroblastoma, and when the imaging workup was done, so there was a large mass which was again causing compression of aerodigestive tract. And what is this that we are seeing in addition over here? There is intracranial extension as well, right? On the MR is depicting it better, that through the foramen there is this enhancing soft tissue. In addition to encasement of the carotid, there is intracranial extension as well. And why is it important? Because of these, right? So anytime somebody says neuroblastoma, the first thing that should come to your mind is, somebody wrote it in the chat box also. So yeah, great. So the first thing that should come to your mind is IDRFs, right? So what are the IDRFs in the neck and what all is positive in our patient? So important IDRFs positive in our patient are the tumor encasing your carotid artery. You can't even see the IJV, so that is encased as well. And also there is extension to the base of skull. So if IDRFs are positive, your tumor automatically becomes at least an L1 lesion. I'm sorry. Yeah. Okay, so from neuroblastoma, then we move on to the next and most important category of infiltrating masses in children, which is rhabdomyosarcoma, right? So, rhabdomyosarcoma is actually the most frequent soft tissue sarcoma in children, right? And it is located in the head and neck in a significant number of patients. So important in rhabdomyosarcoma is that there is a subsite based classification for prognosis. Okay. So this is the most important subsite to recognize, to report, and also most challenging to treat, which is called the parameningeal subsite, which means anything close to the meninges, right? So nasal cavity, nasopharynx, PNS, and skull base. Other better sites are the orbit and others lower down soft tissue such as the oral cavity, lower pharynx. Upper pharynx is parameningeal. So why is parameningeal bad news? Parameningeal is bad news because A, it presents late because there are only vague symptoms, right? So there is some nasal discharge, airway congestion, and also once it presents, it is difficult for a surgeon to remove, right? And in new RMS, you have to understand that surgical therapy is still very, very important, right? So when we go into onco MDTs, oftentimes the discussion is that in RMS, you go and remove whatever is possible and then the rest will be dealt with. So that's why a parameningeal site is bad news. Okay. There are also histological subtypes of RMS, and the most common in children in the head and neck is the embryonal subtype, which is not bad in terms of prognosis. So this is the TNM staging of rhabdomyosarcoma, and why I have brought it to show you is that how important cranial parameningeal subsite is in itself, that it upgrades a tumor to stage 2 or stage 3, to stage through 2 automatically, right? Whereas if it is in the orbit or other favorable sites in the head and neck, it can still be stage 1 depending on your other NNM features. So let's see what parameningeal RMS looks like. So this is again a 2-year-old boy with breathing difficulty. Like I said, there is only vague symptom, right, in these children. So there is this nasopharyngeal mass, which is T2 hyperintense. And look at the fluid which is seen in the nasal cavity due to the congestion caused by this mass, right? And there is intense enhancement again in this. We actually did a dynamic MR as part of a project, and there was misleading contrast enhancement curve. If you see in this is a type 2 curve. Somebody would see this and say that we are dealing with a benign lesion, but that is not the case. This is characteristic location, characteristic age group. So be very alert for these lesions. And you have to say that, yes, we may be possibly dealing with a parameningeal RMS. Endoscopic biopsy was done and this was proven. So this is another child with parameningeal RMS, which you see if you leave it be, how fast it grows and where all it can extend, right? So again, this tumor started in a similar subsite. It started in the nasopharynx, spread anteriorly, laterally, and also up and down, right? So you can see how bad it is. Cannot undergo resection. There is intracranial extension, there is lateral extension, and also there are hematogenous metastasis. So this kind of aggressive looking lesion in a child with characteristic location that is in and around the parameningeal sites is, you are can make a safe ballpark that we are dealing with an RMS, of course, still needs biopsy to prove and also for molecular diagnostics. So the major categories we have already discussed, which are neuroblastoma and rhabdomyosarcoma. Now let's see what other entities can present with infiltrating masses in children. So again, this is a 9-month-old girl who presented with a fungating mass in retroauricular region. So what happened? There was this large mass. First, it grew medially. So what did it do? It eroded the petrous on the right side, right? Also eroded some part of the pterygoids. Then it eroded further superiorly and went into the extradural intracranial compartment. Okay. And then it developed a very interesting pattern of growth. What did it do? It grew along the eustachian tube. Okay. And started falling into the oropharynx. So we did an FNA, but the child bled so much because it was a vascular mass that we could not get a good sample, and it was presumed RMS and treated with chemo for 1 month. After 1 month, the child comes, and what happens is intracranial extension reduced, but okay, external component also reduced, mass is no longer fungating. But what is this? What has happened? So the part which had followed along the eustachian tube has now taken the path of least resistance and grown into this big bulbous hanging mass within the oral cavity, oropharynx, and also extending till the hypopharynx. And please note that it is T2 extremely hyperintense. Okay. And what, so yeah, on the post-GAD images, again, there is intense enhancement. There are some flow voids as well. And I wanted to show you that this is the extension which is seen through the eustachian tube into the nasopharynx, oropharynx, and then going further down, hanging like a pedunculated lesion. And what do we see on the diffusion? It is not showing any diffusion restriction. So what did we call it on our imaging? We called it an aggressive lesion. Why? Because there was bony destruction. It was growing along the planes, but then at some point it started just following the path of least resistance and hanging in the oropharynx, hypopharynx. And also so it was locally aggressive, but not showing typical malignant characteristics in terms of there was no diffusion restriction. Finally, again, endoscopic biopsy had to be done from this part in the oropharynx, and it showed that there was an inflammatory myofibroblastic tumor. What were the clues which we should have known? One is that of course, initially difficult to say what the lesion is, but once it started growing along the oropharynx, the intensity to hyperintensity, lack of diffusion restriction, and the intense enhancement could have pointed, but again, this is a biopsy diagnosis. From soft tissue tumors, we are now going on to bone origin of lesions in children. So again, this is the poster boy of bony lesions in children. The diagnosis I have already written. How we can come to this diagnosis, I will show you, and how it's different from the parameningeal RMS. So again, lesion location is similar. It is located along the parapharyngeal space, and the child is presented with painless proptosis. But how is it different? If you see that what is the epicenter of the lesion, right? So over here, this is your normal sphenoid body. There is complete destruction of the sphenoid body and the sphenoid wing. And in fact, tumor is seen on both sides of the destroyed bone. Over here also you can see, and it's causing a lot of bony destruction. Pterygoid body is also eroded. Pterygoid plates are not seen. And in fact, there is replacement of the normal marrow signal of the clivus as well. Again, intense enhancement is seen. So when you are able to localize the origin of the lesion to bone rather than to soft tissue with secondary bony erosion, we have to think about bony tumors. And the first among these will be Langerhans cell histiocytosis. Coming on to one more important group of tumors, neck lesions in children are nodal masses. So again, this is an 11-year-old girl with progressive neck swelling. Now, what do we see? That there are bilateral, homogeneous, discrete nodes in the posterior cervical space. And so again, we are talking about multimodality. So this is one of the instances where we use PET a lot. And in fact, PET is the only reliable modality for staging. So this is, we are dealing with a lymphoma. Right. So what is the role of different modalities in lymphoma? There are two competing modalities in today's world. One is a whole body MR, which can help you in staging. And one, of course, which is the current gold standard, is a PET CT. So why is it important in lymphoma versus other tumors is that Hodgkin lymphoma typically resolves with fibrosis, right? So there would be persistent nodes even post therapy. So that's why, in order to look for the metabolic activity, the whole body MR with diffusion to some extent, and importantly, the PET CT helps you in staging. So again, what are these homogeneous enlarged nodes in multiple stations, which are non-necrotic? So that is how you would say it's a lymphoma. Why Hodgkin versus non-Hodgkin is, non-Hodgkin usually involves extranodal sites in the head and neck preferentially, most importantly, the Walde's ring. So this was a classical Hodgkin lymphoma on biopsy. This is another entity which often presents with nodal masses and difficult to differentiate on imaging, but there are some pointers which we will discuss. I'll show you. So again, this was a 3-year-old boy with first pointer is that there was both eyelid and neck swelling. Again, there were these large aggressive looking nodes with good hilar vascularity, although the rest of the node did not show much of increased vascularity. And then on the CT, what was seen, there were these, again, very large enhancing homogeneous lymph nodes, what is called as, in clinical parlance, is bulky lymphadenopathy, and also a similar looking lesion enhancing mass in the eyelid. So this is the child actually, the nodes were palpable. So we did not do the guided sampling. Pathology did it. And pathology was kind enough to share this slide for us. This is a book picture of a very fancy term, which is called as emperipolesis, which means that a histiocyte, when it eats up nuclei, other nuclei such as lymphocytes, that is called as emperipolesis. And what is the entity that we are dealing with? We are dealing with non-Langerhans cell histiocytosis. And which one is common in children? All three actually. But HLH we know is a more of a multidisciplinary diagnosis with diagnostic criteria. When we are dealing with cervical lymphadenopathy, we are dealing with Rosai-Dorfman disease, right? So what does it have? Typically, it has this painless large lymphadenopathy, and in addition, it can have what we saw, eye orbital lesions as well. And also you can see dural based masses, which is said to mimic a meningioma. This other lesion, a juvenile xanthogranuloma, is also actually suspected clinically. You have these yellowish papules in the skin, right? So it is important to be aware of this entity of non-Langerhans cell histiocytosis as well. When lesions are not clinically fitting into lymphoma, you should be aware of this possibility and go ahead and suggest sampling. So to summarize neck masses in children based on morphology, we saw cystic, there are mixed as well, which we saw, and there is solid. So cystic, we spoke about branchial cleft cyst, we spoke about lymphatic malformations, and then there are these other cysts which can be seen, congenital cysts, which are laryngeal, there are thyroglossal cysts as well, which can be seen. When we come on to solid cystic, we know, we already saw this, mixed malformations, that is venolymphatic, capillary lymphatic. Germ cell tumors are also solid cystic many times. Then coming on to purely solid tumors, which we have spoken about in detail today. So there are soft tissue tumors, which can be, we know there are some with characteristic morphology like vascular tumors, adipocytic tumors. And then there are those which are infiltrating and cannot really be differentiated, which include, which is RMS and these fibroblastic tumors. Coming on to bony origin, we already saw LCH. Even Ewing sarcoma can be seen in the head and neck, and other nodal lesions we have spoken about. Neuroblastoma again remains a very, very important and rather the first differential in case of solid tumors in neck in children. Now we will be going on to the next slide is stuck. Yeah. So this actually the classification is less important than what is this I want to bring out today is that there are some lesions which like I said, the buck stops with the radiologist, and you can go out on a limb and say that, yes, I know what I'm dealing with. We don't need anything further. Some of these characteristic ones are like branchial clefts, lymphatic or venolymphatic malformations, and two of these we saw today, lipoblastoma and hemangioma. Others are where you can only suggest the diagnosis that yes, I think we are dealing with this, but again, it needs biopsy either for confirmation or for prognostication and treatment, like in many tumors, like we saw in RMS and neuroblastoma. There are some where which show characteristic, no, sorry, which show suggestive imaging like we saw in the IMT, but again, that is still remains a biopsy diagnosis. You cannot say that, yes, this is an IMT for sure. And yeah, once you do have fat containing lesions, you can suggest that this is a germ cell tumor. It may be mature or immature based on morphology. So as a radiologist, particularly when you're dealing with children, it is always a multidisciplinary diagnosis. You should be part of a multidisciplinary team. And it is important for you to recognize where you can take the call that, yes, I'm dealing with this, and where you can suggest the call and then suggest further sampling, and then go ahead and do that sampling so that diagnosis is reached timely. So from children in general, which is a very large and heterogeneous population, we are now coming on to this specific age group, which is less than 1 year, infantile masses. So why are we talking about these? Because these are different from the rest of the pediatric age group in that older children often have, younger children often have congenital lesions and peculiar lesions, which we will see in the subsequent images. Okay. So this is, first we start with cystic masses. So this is a 6-week-old boy with respiratory distress. So we have already seen this entity, but just to show you, it can also present with congenital, and children can be born with respiratory distress. So there are large cystic masses which are multilocular. There is an intra-airway component to this. There is also a retropharyngeal component to this. And what is it doing? It is encasing the carotid vessel. This is the virtual bronchoscopy to show you that there is actually a significant airway narrowing, which is why the child has been tracheostomized as well. So why did I bring this today? It is not specific to infancy, but like I said, it is an entity where you can make an imaging diagnosis and actually go ahead and treat this child. So how did we, this is the ultrasound which showed us this cystic mass, and then we went ahead and so these are the contrast runs, and then following to check for venous communication on the DSA, and following this we put sclerosant, that is foam mixture of polydocanol, and we could get the child off the tracheostomy in about 2 sessions of sclerotherapy. So this is when again, characteristic imaging, you decide the diagnosis and intervene fast so that the child is relieved of their acute symptoms. Okay, so from cystic, we now move on to this more complex category, which is solid cystic. Again, this is a neonate who had already came to us with a neck mass detected on antenatal ultrasound. So it showed a cystic neck mass. So we went ahead and did the ultrasound when the child presented. So it showed us this multilocular cystic lesion. But in addition, what did it show? It also showed well. Then we decided that child needs cross-sectional imaging for delineation of anatomy because it's solid cystic. So radiation is what we had missed on ultrasound. So that there was a midline associated lesion with this, right? So so this is the skull base extension I was talking about. So once there was a midline associated lesion, we knew what we were dealing it and we called it as such that this is a congenital teratoma. So again, there are some characteristic features like this one in a solid cystic lesion, which is congenital present since birth. You can say that yes, we are dealing with a germ cell tumor or a teratoma. So now coming on to another solid cystic entity, which is again seen in very young children, neonatal infant age group. But this one is not so characteristic on imaging, just brought it to show you that there are aggressive tumors as well, which can be seen in this age group, particularly sarcomas. And again, once when you see this entity, you should promptly say that yes, this is an aggressive lesion, needs biopsy for classification and treatment. So this was a child with progressively increasing swelling, again present since birth. He was 3 weeks old when he presented to us. He was carrying an outside ultrasound which showed this solid component. There was an anechoic component. Again on the MR, there was this dumbbell-shaped intracranial extension into the extradural space as well. Within 3 weeks, what happened to this mass? The mass grew by leaps and bounds, right? So the cystic component increased, the solid component increased, the calvarial defect just became bigger, and look at the extent of the intracranial extension, right? So this is an entity, just want to sensitize you that this primitive myxoid mesenchymal tumor. So there are a group of tumors which are only seen in infancy. This is one of them. Fibrous hematoma is another one. And we will be seeing a couple of more entities also. But again, difficult call on imaging, but you can just say that yes, aggressive lesion needs biopsy and needs to be managed by an oncology team. So again, infantile masses solid. So this is one where you can say what we are dealing with. So this is congenital goiter. Now, what does a congenital goiter look like? So this is a 13-hour-old boy who again had a congenital detected lesion on antenatal ultrasound. So we went ahead and did the CT. And what do you see? So high up in the neck. Actually, this is an infrahyoid origin. If you remember, the thyroid has but because there is congenital hypothyroidism, the gland is enlarged, it is intensely enhancing, and it is extending into the suprahyoid compartment as well. How do you say that this is congenital goiter? You scroll right down, locate your normal thyroid gland, and you will be able to see the direct extension of the thyroid lobes into the retropharyngeal region, right? So, characteristic hyper enhancement, characteristic origin with the compartmental extension. This does not need any further imaging or any sampling. You can say that this is enlarged thyroid gland. Similarly, this is another entity where you can say so, a fat-containing lesion, which is also present since birth. Why? Do look at the age of the child. She is only 4 days old. And it is, so look at this lesion, well-defined, only fat, no soft tissue, straight away congenital teratoma. Child went for surgery and was removed as such. Okay. So, we are coming to towards the end of our. So we already saw a neuroblastoma in the older children age group. Sometimes neuroblastomas can also be present congenitally. It is important to remember that. And how do you say that you are dealing with a congenital neuroblastoma? Again, if you see calcification within a mass in a child where the mass is present since birth, you are most likely dealing with a neuroblastoma. How is a congenital neuroblastoma, different from those in older children, congenital neuroblastomas typically behave much better. Sometimes they even show spontaneous involution. This was not the case in our child, but again, there was a retropharyngeal mass. Child had noisy breathing since birth and on the ultrasound. So this is the airway wall, and in relation to the wall of the airway, there was this lesion which showed central calcification, which was seen on the CT as well. Encasement of vessels were there, so we called it IDRF positive. A child went in for chemotherapy. Post chemotherapy, mass shrunk a lot. You can see airway caliber is nearly reduced. And also, again, this characteristic longitudinal kind of orientation, which alerts you that, yes, this is something of neurogenic origin. Now the IDRF is negative. There is the vertebral artery which was encased is now free. And so this child underwent surgical resection for this tumor. Okay, so I was telling you that there are some lesions which are peculiar to infancy. One which we had seen, which was the myxoid mesenchymal tumor of infancy. This is another such lesion. So this is in this child, the clinical context is important. Why? Because there is a neck mass and there is overlying skin discoloration. Okay, so this is a coronal image, and what does it show you? It shows you that the origin is bony. So in the older child, when origin was bony, what was our first differential? It was LCH. But this is a young child, an infant. There is skin discoloration with the jaw origin. And there is a multiseptate tumor. A multiseptate tumor. So this is one of those Aunt Minnie kind of things where a tumor arising from the mandible means a jaw tumor with skin discoloration is this entity. So this is melanotic neuroectodermal tumor of infancy. Right. So there are some times when you can look smart in the MDT and say that, yes, I know what we are dealing with without even touching the lesion, although you will eventually need to sample and prove your diagnosis. But this is one of those where based on the age group and the clinical presentation, you can make an intelligent guess about the diagnosis. So again, a similar classification like we had seen for older children into based on the composition or the morphology. Cystic lesions, again, we saw lymphatic malformation. A teratoma can be cystic. Solid cystic can be either malformations, even germ cell tumors, or rarely even aggressive lesions. And in the solid group, it is important to remember that these tumors, neuroblastomas, teratomas, are present congenitally, as is this, which is a congenital goiter. So again, this summary, which is that when you can say that, yes, I know what we are dealing with, and when you can say, I think I know what we are dealing with, but I still need to go in and sample. So again, lymphatic and velolymphatic malformations, nothing further required. Fibromatosis coli is sort of an everyday story in pediatric ultrasound where children come with lumps along one side of the neck, and congenital goiter we just saw where you are able to trace the origin from the thyroid, and of course it's very, very high attenuating. Then again, we come on to the next group where imaging features are suggestive, but you still need a tissue diagnosis. One is this one, neuroblastoma, and others where fat content is present. So you can say that possible teratoma, but mature or immature, don't know. So with this, I come to my conclusion. Yeah. So to conclude, I just want to say that spectrum is very different in children, and particularly in this age group, mainly neonates and infants, which are a lot of congenital lesions, and particularly those specific tumors which are seen only in infants. Otherwise, there is a host of bone and soft tissue tumors. Again and again, I will stress that there are some which have characteristic appearances and you can avoid biopsy. There are others where you can say that, yes, possibly this, and we need to go in and sample. So these are my references. Thank you very much.
Thank you so much, Diksha. That was just a phenomenal talk, as expected. Superb images, comprehensive coverage. And we have some time. So, there are some questions from the Q&A. Let's start
Yes.
testing.
So we'll go on to the.
So this is an anonymous attendee asking how to differentiate lipoblastoma from a dermoid if it's a
Okay.
pelvic lipoblastoma.
Right. So, lipoblastoma is not an encapsulated tumor. Okay. So, like I showed you, that a lipoblastoma is a very insinuating tumor. So you will see that it will go wherever it will find space. It will go between bones. It will go into the foramina. But first of all, from a teratoma, there is no soft tissue component. It is pure fat. From a dermoid cyst, it is not a well-defined cyst. It is an insinuating lesion that goes between wherever it finds space, basically. Explain two cases of branchial cyst. Okay, so branchial cyst has characteristic location, right? A branchial cleft cyst, depending on the types, the location, but and branchial cyst is lined by true epithelium. So it has a very thin, nice, well-defined enhancing wall, and the location, like I showed you, if you want me, I'll go back to it as well. So, can you see my screen? Screen is visible?
No, you'll have to share.
Sorry, I'll just share again. So, if we come to this is a characteristic location for a second branchial cleft, okay? Between the angle of the, posterior to the angle of the mandible and anterior to the sternocleidomastoid is a characteristic location for a second branchial cleft. A first branchial cleft is in relation to the external auditory canal, and a third and fourth branchial clefts are actually lower down. If you remember, based on embryology, based on pharyngeal pouches. So, a unilocular cyst with characteristic location, we can say that we are dealing with a branchial cleft cyst. Similar is a thyroglossal cyst, which is again a characteristic location midline in relation to the hyoid bone. But, and of course, we know from our MBBS days that it moves with deglutition. So, that is how you are able to tell a branchial cleft cyst on imaging. Okay.
Difference between a soft tissue hemangioma and a venous malformation.
Okay. Again, we are talking about multimodality. So, let's start with ISFA classification. A vascular malformation is basically a soft tissue hemangioma is a tumor versus a vascular malformation is so there is no soft tissue basically in a venous malformation. Sometimes in microcystic it may be seen, but a hemangioma is a mass. It presents as a tumor, a mass. So if you do an ultrasound, you will see a well-defined echogenic mass, which is showing intense vascularity. Then on multimodality means you'd go in and do the dynamic contrast MR. And then what do you see on that? Your hemangioma will follow the blood pool. So on the arterial phase itself, you will start seeing enhancement, which will progress. A venous malformation is venous or venolymphatic combined is most commonly seen. It will not show any enhancement. It will show delayed enhancement, although it will retain the contrast. So that is how you are able to differentiate on multimodality. First, whether there is a tumor or not means whether there is a mass or not. And secondly, based on the enhancement characteristics on your dynamic MR. Should we use the term round cell tumor if we are suspecting RMS or mesenchymal tumor? I think it's not a bad idea to use round cell tumor, but eventually, you can only suggest the invasion or the aggression of the lesion, right? So, your histology is going to come from the sampling, and also now it is more a study of mutation analysis. So, using round cell tumor or not is not going to change the treatment or prognosis, but yes, it does place the lesion in context to whoever is dealing with your report, an oncologist or a surgeon. So yes, tissue origin. Okay. So this, again, if I can go back to the LCH case, basically you need to look for the epicenter of the lesion, like we were taught. So if the epicenter of the lesion is in the bone with extension to both sides of the bone and there is bony destruction, then you will say that bony lesion, versus if you have a soft tissue origin, which is so, like if we go back to that LCH case, the sphenoid body and wing is completely wiped out. Yeah. So here, if you see the sphenoid body and wing is completely wiped out, there is bony destruction in this. Whereas if we see in the child with, say, this parameningeal RMS, the predominant origin of this is soft tissue, right? It is in the nasopharynx, then it has gone into the parapharyngeal space, then it has gone into the parotid space, and along the way, whatever bone it found, it has eroded. So basically, again, going back to very basic concepts, epicenter is an important factor. Okay, dynamic study for vascular malformation. What is the protocol and cutoff? Okay, so there is something called a 4D track MR sequence. The 4D track MR sequence is basically, so the fourth dimension is time and it helps you follow the blood pool. So you can actually get cine images where you can play videos and compare enhancement of the blood pool with enhancement of the lesion. Cutoff between high and low flow, like I said, if there is arterial enhancement and shunting, means if there is early venous opacification or early venous drainage on the MR or even on DSA. So that would be a high flow, which means that it is not going into the capillary. It's directly growing from the artery into the vein. Whereas in low flow, which are typically venolymphatic, you do not see that early enhancement. You see kind of delayed enhancement and they tend to keep the contrast within. They tend to retain the contrast. High flow will take it up early and send it away early. So that is how you differentiate. Anything else?
Yeah,
No, I think we are done. Anything in the chat box?
That answers all the questions. So thank you so much, Diksha. This was a fabulous, very comprehensive talk. And